Good day, everyone. My name is Michael Antonellis, and I'm the Vice President of Marketing and Communications at the MGFA. Welcome back to our second day of the annual MGFA National Conference, and I'm really excited and honored to kick off today's sessions. I wanted to take a minute to talk to you about MG Awareness Month. As you know, June is MG Awareness Month each year, and it's a time to volunteer and spread awareness about the disease and educate people about the challenges that the MG community faces. But this year, we're turning awareness into action. And we're actually changing the theme this year to MG Action Month in 2021. And we're asking all of you and everyone across the MG community to take action and do something tangible to show the wide influence and power of our community. There are so many calls to action that you can engage in. This year, we'll have online seminars that you can participate in. You can join our online Paint and Sip Art Night or wellness seminars to showcase that we are all so much more than our MG. And we'll show off our talents and our creativity. We're asking you to engage with media members, write op-ed articles about the disease, or tell your story to local journalists and get them to cover the challenges and opportunities for MG patients. Reach out to your members of Congress this week and in the coming weeks and ask for a proclamation for MG Awareness Month or advocate for key rare disease bills such as the STAT Act. You can contact management realty companies for buildings and structures that we can light up in our teal color and submit photos of your creative awareness activity to MGFA and light up our global map. You can also submit a recipe for our MGFA cookbook or send us t-shirt designs, and the winning designs will be made into actual shirts. And of course, share our MGFA social media posts with your friends, family, colleagues, and others across your networks. There are so many things you can do this year to take action and to turn awareness into action. Check out the MGFA website for our awareness page and awareness toolkit, and we'll provide some basic training in the coming weeks. And now, our first presentation today is called The Power of Hope. I am pleased to introduce our distinguished presenter, Dr. Jeffrey Rosenfeld. Dr. Rosenfeld is a professor and associate chairman of the Department of Neurology and is the director for the Center for Restorative Neurology and director for neuromuscular ALS programs at Loma Linda University Health Systems. His clinical activities over the past 20 years have largely focused on the development of unique neuromuscular programs. His emphasis has been on development of approaches across disciplines to provide aggressive, proactive care for patients with neuromuscular disorders. And most recently, he has created the Center for Restorative Neurology at Loma Linda University School of Medicine in San Bernardino County, California. And this has involved the organization of a large multidisciplinary team for the full-time comprehensive care of patients with a variety of neurological disabilities, including myasthenia gravis. Thank you, Dr. Rosenfeld. We appreciate your participation.
Thank you very much, Mike. It's really my pleasure to be here, and thank you all so much for tuning in and joining us this morning. This is a very different kind of talk for me. I will tell you that I'm very comfortable speaking about myasthenia, and I've done that quite a bit to patient groups, to residents, to other physicians at conferences and such. But this particular talk is a little different. It's different because whereas I'm used to talking about the science or new advances or even some of the treatments for myasthenia and how that benefits the myasthenic population, this is a little bit different because this is really coming from my experience of how your attitude, your approach to your own disease can have such a profound effect, perhaps even more than in other neurological diseases that I have treated along my career. And that's what we're going to talk about today. I call it the power of hope, and hopefully you'll see why in just a moment. The other reason that this is a little different is when I agreed to do this talk some time ago, and I'm very grateful to the organization for inviting me, I had envisioned this to be a very interactive talk. Of course, I didn't realize the logistics of the virtual communications at the time, but I really wanted to see what you were thinking about what I was saying. And that's, of course, very difficult, if not impossible, during one of these virtual presentations. But I'm going to invite you to use the Q&A function on the platform here to comment as if you would raise your hand during a talk. And to the best of my ability, I will try to take note of those along the way and make comments and make that as conversational as I can. And then at the end of my comments today, there'll also be a time for question and answer. So you certainly can write in comments and questions at that time as well. But feel free to write them along the way, and I'll do my best to try to make this as almost conversational as it can be. So let's get started here. And I'll tell you that what we're going to do today is first talk a little bit about why do we even mention the power of hope for myasthenia, perhaps even differently than we would for any other neurological condition. I call it the MG paradox. That's my term. And the paradox is myasthenia is one of the disorders in neurology that we understand so well. It is perhaps one of the best understood conditions in all of neuromuscular. Yet at the same time, there are so many things we don't understand. We don't understand what makes it worse sometimes, what makes it better sometimes. And there's a big paradox, if you will, between how much we understand and how little we know. And we're going to explore that a little bit. We're going to start off just talking about just a short time about the science of MG, so we all understand what happens in a patient with myasthenia. I expect for many of you that'll be a review, I'd imagine. And then the real crux of it is how can your immune system, which drives the condition and drives the problems you have with myasthenia, how can that be affected by your attitude, by your mental health, by your outlook, can actually affect your immune system and as a result, impact your myasthenia. And then what can you do? We'll get to that in just a moment. So there are some takeaway messages. If I lose you along the way, this is what I'm hoping that you'll get from the talk. Number one, myasthenia is a very treatable disease. It is perhaps one of the most treatable neuromuscular conditions because we have so many choices. We have and growing, the number is growing, and it's almost an embarrassment of riches, if you will, how many choices we have as practicing neurologists to treat myasthenia and its various manifestations. Number two takeaway message is your attitude, your emotional health can and does affect your physical health. Always avoid fear by choosing hope. Now that's much easier to say than it is to do, but myasthenia, for reasons I'll show you in a moment, is a disease where fear is very common. Fear of the unknown is very common. Hope is the treatment for fear. And this is one of my favorite expressions, which I use in my practice. It's my expression. And I say to the patients, if you get your head in the right place, your body will follow you, which is the same thing as to say, understand your emotions, your attitude, your outlook towards the disease, and your physical health will most certainly be impacted. Now, this is a very busy slide, and I apologize, but it really wasn't meant for you to read the details. It's a slide that shows, I neglected, or the citation didn't come on this slide, but it was a recently published review paper, that showed the discovery timeline for what we know about MG. And those green downward pointing arrows on the top of the timeline, those are all milestone discoveries in myasthenia. And this slide goes up to about 2019. And of course, there have been a couple of things in 2020. The blue upward facing arrows on the timeline are pharmacologics, new drugs. I wish we had this timeline for several of the other conditions that we commonly treat. This is a very busy slide, which is, as I say, a very fortunate opportunity to have so many advances, to have so many therapeutics. So if there were nothing else that you had, in as much as you might wish that the disease had never affected you, you are affected by a disease with many, many treatment options and many, many prior and ongoing discoveries. And that is much better than being affected by a disease where there are few discoveries and few options. Now, this is a little video which sort of highlights what you probably already know. A muscle has receptors on it, and those receptors are required for contraction. A nerve releases a chemical called acetylcholine, and that migrates, literally floats across a little cleft, binds the receptor, and the muscle gets shorter. And then there's an enzyme that inactivates that chemical to give the muscle a chance to respond to the next impulse. But in myasthenia, there are fewer receptors. So with fewer receptors, even if you got the same amount of chemical released from the nerve, which we do, the chances of it finding one of those receptors before that enzyme inactivates it is much less. And as a result, the muscle doesn't contract. So as you may already know, the reason why there's weakness in myasthenia is because the chance that that chemical, acetylcholine, will bind to the fewer number of receptors that are left is less. And as a result of not binding, there's not contraction. So in another cartoon, this is basically a picture that shows on the bottom box that the myasthenic junction between the nerve and the muscle is different. It's different because the receptors that aren't there have changed the architecture of that structure. You can see there's less curves there's less involutions on the postsynaptic membrane on the muscle. And as a result, it is a less functional connection. Now, the reason why that occurs is because of antibodies. Antibodies are directed against the receptor, and as a result of the antibody binding, I don't think you can see my cursor here, but as a result of the antibody binding on the bottom right box, that receptor is no longer functional. That receptor is no longer able to bind that chemical to make the muscle contract. So most all of the treatments, with the exception of one, most all of the treatments for myasthenia are directed at the immune system to stop the antibody from being produced so that it will not bind that receptor. That receptor will be left intact and able to function for the muscle. The only medication that acts in a different mechanism than the immune system is Mestinon. Mestinon has nothing to do with your immune system. That what Mestinon does is it inactivates that enzyme that I showed you in the previous cartoon with the scissors that inactivate the chemical. It quiets down that enzyme. So as a result, the acetylcholine that's released has a greater time to stick around, a greater chance to find that fewer number of receptors in the myasthenic muscle and still get you some function. So this is a picture of kind of a broad strokes about why we use more than one medication and why we're glad to have more than one medication in myasthenia, because they don't all act on the same timeline. And I'm sure I'm speaking to many people that are well aware of this phenomenon, but Mestinon, pyridostigmine, acts very quickly, within a half hour, within 40 minutes, and it lasts for 3, sometimes 4 hours, or occasionally more. Plasma exchange and gamma globulin do not usually act right away. They may act within a week to 2 weeks, 3 weeks, and the effect lasts about 6 weeks. Whereas prednisone may act fairly soon, within a day, 2 days, and the real benefit is weeks to months down the road. But the majority of the drugs that we use in myasthenia, the majority of these are not active for several months. So if we start something like azathioprine, for example, to use just one, or even mycophenolate, Cellcept, we're not really expecting a very significant benefit for perhaps 4, 6, or even more months down the road. The reason I'm bringing this up in a talk about hope is I think it's helpful to understand a little bit about the pharmacology and the science behind what you have, because as you better understand what's going on, you're better understanding how to get your head in the right place so that your body will follow. Now, predicting how people do in myasthenia can be a tricky business. There are some data that suggest disease severity, depression, older age, and persons with larger body mass indexes were major determinants of quality of life. Interestingly, of all of these factors that I list on this slide, the one that is the most controversial, that is, not everybody thinks it's true, is disease severity. Well, you'd think, what else could better predict how a myasthenic patient's going to do than how bad their myasthenia is? Well, that's not always true. It turns out to be some of these other things are more predicting of quality of life than is actually the disease severity. And I've experienced this in my own practice. Some patients that have myasthenia that's quite severe and many exacerbations and difficult to control, they seem to get along better than some folks that have less severe symptoms. And that kind of observation perhaps is what triggers in my own mind why. And that's what we're talking about today. So let me start out with what you already know. All of you that are affected with myasthenia are probably already aware that this can affect your lifestyle. It affects your lifestyle by giving you some limitation. It could be vision, it could be breathing, it could be strength, it could be endurance, or it could be all of those things. But there's no question that it affects your lifestyle. Add to that this disease occurred out of nowhere for you. That is, you didn't do anything wrong to get this disease. This was not self-inflicted as some other diseases in medicine are. So you probably didn't see this coming. And it definitely had an impact on you, and it's ongoing. Let me just see there we go. It's a lifelong condition. So take those three things together, that it's affecting you, you don't know where it came from, and it lasts for your entire life. And the most important kicker, the most important thing that makes myasthenia perhaps different than some of the other conditions that we treat in neuromuscular disease is that it is unpredictable. It's unpredictable because you never know when it's going to flare up. There are perhaps some kind of triggers that some of you may have identified, but for the most part, it's unpredictable in that if you were to plan a once-in-a-lifetime vacation trip and you were to get an exacerbation of your myasthenia before you were going to leave, that's very unnerving not to be able to know. Now, if you add in these things, the ongoing disability, these not self-inflicted, the lifelong condition, and that it's unpredictable, what does that result in? Well, in my experience, that results in fear. It's an uncomfortable feeling to not know what's coming next. And that, I think, affects myasthenic patients perhaps more than it does other patients with different neuromuscular conditions. Now, fear, in my experience, fear is the most disabling of all the conditions. I also have a sizable practice for patients affected with ALS, Lou Gehrig's disease. And I will tell you that for different reasons, fear affects that population as well. And fear is very disabling because it can, as we say, take you out at the knees. It disables your clear thinking. It not only makes you feel uncomfortable, but it makes you do very poorly because you're constantly afraid of what comes next. So what do we do about fear? If you look at these factors that I just listed, it's almost inevitable that a person would be afraid. How could you not, if it's an unpredictable thing that you had nothing to do with, that is going to last your whole life, and it creates an ongoing disability? Of course, fear. Well, in my experience, there is only one antidote to fear, and that is hope. If you have a hopeful outlook, if you think, even though you might have been dealt a curveball, it is treatable, and it is treatable. If you can really embody that, you really believe that, you will do better. In my experience, I have seen patients, as I mentioned, with quite severe disease, but a very optimistic, proactive, let's get busy type attitude. They do much better than those with more mild symptoms that are just constantly fretting about what could come next. Now let's talk about hope, because it is the title of the talk here. So hope is what psychologists call a psychological resource that influences ability to cope with stressful, life-threatening situations. And hope is often associated with quality of life. But in reality, if you think about, so all right, so he tells me I should be hopeful. What does that mean? Well, hope and coping are really two interrelated concepts. So we all cope with situations all the time. Some of them are not so serious. Some of them are involving more problem solving. But coping leads to more hope. Now, there are two strategies in psychological constructs for coping. I have patients that adopt either one of these, and I think it depends upon your personality, how you look at the world. So an emotion-focused coper, or a person who adopts emotion-focused coping, they look at the big picture. They say, yeah, I'm going to get through this. I know that I've been dealt a curveball. I know that I feel crummy right now. I wish I felt better, but there's going to be better days ahead. Just don't worry about that. So we call it wishful thinking or minimization of the avoidance. This is a person who just says, I'm not exactly sure how this is going to go, but I know it'll get better. Even if I'm having a crisis, I know I'm going to get past this. Now, a problem-focused coper, or a person who uses problem-focused coping, they handle life a little differently. These are persons that come in and they say, I have double vision. I want to fix the double vision now. I want to fix the breathing now. So they're much more granular. They look at a team like we have a multidisciplinary team I'll speak about in a moment, and they say, who in this team is going to help this problem? And they often come in with a plan. Sometimes they come in with printouts from the internet. Sometimes they come in with questions specific to a certain medication, but it's very cause and effect. They take their problem and they take it apart. This is like an engineering approach to managing your disease. What am I going to do about it? One way is not better than the other, but both of these coping strategies can lead to more hopeful affect, more hopeful attitude. There's a lot of literature here. There was more literature that's been written about quality of life and coping, quality of life, and disease outcome than we have time to summarize. A couple of, though, that I am going to focus on this one. And by the way, if anybody's interested in any of these articles, I'm happy to send them to you by email if you want to contact me after this talk. But what's interesting about some of these articles is there have been a number of studies where they've looked at actual immune markers, immunologic markers, and how they changed after emotional or therapeutic type interactions for patients that are learning how to deal better. For example, this paper that was on the previous slide, Mindfulness, Meditation, and the Immune System. I'll spare you the details, but what they found was patients that underwent meditation, mindfulness meditation, and some yoga, I believe, actually affected the serological in your blood, the markers for inflammation, for cell-mediated immunity, and for biological aging. Now, this paper was not about myasthenics, so there was no implication about the myasthenia, but it was very interesting. I believe there were 20 trials, 20 randomized trials that they looked at, and I have an excerpt. This is also quite a busy slide. I know you're not going to be able to read this, but I'll blow up just a portion of this slide so you can see what the text is. Each one of these lines is a summary of a different article that looked at the effect of either meditation or mental health or outlook or some intervention, some behavioral medicine intervention on your actual immune system. I guess it didn't come up. I'm sorry about that. There was an insert that should pop up, but basically on the far right column, it tells you what markers within your immune system actually improved as a result of the intervention. And it's striking. I mean, some of these are the same markers that we're trying to get to improve with medication. And in these studies, more than one of them, they actually improved with the behavioral health intervention. This is another paper dealing exactly with myasthenia, and they looked at 90 patients that had myasthenia, and they looked at the something called the HOPE index, a coping scale, and two measures of quality of life that are well recognized by neuromuscular physicians, the myasthenia quality of life scale and the SF-36 scale. And what they found was that there's a very significant relationship between hope and coping, which makes sense. We talked about that before. Hope and quality of life, also perhaps logical. and quality of life and coping. But what was most interesting was that the quality of life was most correlated with the degree to which individuals adopt a hopeful, proactive, positive type attitude, and not associated with their disease severity. So again, patients with quite severe myasthenia might do better than patients without as severe myasthenia because of what's going on in their head. Not intuitive. This is another interesting paper that came out of Korea, I believe. And so there might be some cultural differences here, but they also measured quality of life in myasthenic patients. And they found that that quality of life was most impacted, of all things, by a change in the caregiver. So the relationships that you have as patients with your caregivers, with your treatment team, very important and actually impacts heavily in the quality of life. In this population, a change in job resulted in a lower quality of life, especially in myasthenic patients, and of course, depression. Another paper that basically showed the same thing, which is that this is a paper that was done at both Brown and Yale, and physical limitations were not the most significant factor affecting quality of life. It was the attitude. So if you take together the notion that your attitude about what's going on, as well as what we know about your immune system markers that drive the disease affected by that attitude, your head is a very powerful medicine to treat myasthenia. Now, in my circles, no pun intended there, but in my practice, we have a very large and intensive multidisciplinary team. I have, and this is very fortunate for myself and the program I set up here at Loma Linda, we have a full-time physical therapist, occupational therapist, respiratory therapist, nutritionist, speech pathologist, and a behavioral medicine counselor. So we have 6 people on the team. And when our patients come in to see us here, the myasthenic patients, for the most part, every time they're seen by everybody on the team, even if they're not having a problem in that area. And the reason for that is I have found in our patient population that the confidence, if you will, the sense that there's a bonding between that patient and that same therapist, because they're here with us full time, is a peace of mind that helps in the coping strategy for many of our patients adopt a hopeful attitude. So even when you don't have an intensive multidisciplinary clinic at your disposal, please understand that your relationship with your treating doctor, your confidence in your treating doctor that somebody, he or she, will know what to do, that they'll have your back no matter what curveball can come down, you should really embrace that. Because in a disorder like myasthenia, where we have so many treatment options, this is very important to not forget. This is not the same as a disorder where nobody understands what's going on and perhaps nobody knows what to do. So just a piece of information that a multidisciplinary team can help assist in your cognitive abilities to deal with this disease, as well can your relationship with the family and your caregivers. Now, there are a lot of interventions that a person can adopt. I borrowed this from our behavioral medicine specialist, Dr. Harris, it's not so much for me to go through these in detail, but you have to figure out what works for you. So for some patients, what we call emotional release, it's not especially therapeutic, but music, art, social interactions, being productive in the community, volunteering, very important. And I would embrace those things because they can be not only fun, but they can be therapeutic. Interpersonal connections, sometimes it's an individual therapeutic relationship with a counselor that helps. Sometimes it's group therapy, sometimes it's support group. In behavioral therapy area, there's cognitive behavioral therapy. That's a very common one. Art therapy is possible. Some people find that their sense of well-being, their hopefulness, their ability to know that they're in control is affected by their diet. And so in those individuals, we encourage to find out what makes you feel good. And it's not the same thing for everyone. But to do that, exercise also has a factor. If you're having myasthenia and you're afraid to exercise, probably you haven't been given the best advice, because you have to exercise smartly. But I certainly wouldn't shy away from it if it's something that brings you peace of mind, that brings you a groundedness. As well, relaxation techniques, the same thing. And as you can see, the other choices on the slide. So there are different options for different people. But if you haven't gone down this route, and especially if you feel that you're not especially at peace with the myasthenia that you have and the way that it's being managed, you might consider some of these interventions. Here's just a little bit more detail about some of the formal therapeutic interventions. It very much depends upon where you seek this care. I think in our program, Dr. Harris, who works with me, is able to offer most all of these things, but it doesn't really make a difference if you found one or you found, if you found one that works for you or two that work for you. But nonetheless, I think, again, just as you have so many different pharmacologic options to treat the disease, there are also a lot of interventions to help with your hopefulness, if you will, or your coping with the disease. So let's just review for a moment. Hopefully, this is what you knew before, and perhaps if not, are coming away from this talk with the takeaway messages. Myasthenia is an exceptionally treatable disease. We have multiple modes of treatment. We have immune modulatory treatment. We have symptomatic treatment in the form of pyridostigmine. We have combination treatments, and we have treatments in the pipeline that haven't even been released yet. This is a very treatable disease. The same treatments don't work for everyone, but nonetheless, the same treatments are available to everyone. Your attitude and your emotions most certainly affect your health. I knew this before I read those papers. I knew this because I've seen the young patient. I'm dealing with a patient right now who is a young woman who just doesn't have time for her myasthenia. And when she gets affected by it and she can't function, she's like, would you hurry up and fix this? I have to get back to what I have to do. I love that. I love the fact that she's annoyed by her disease. She's not afraid. She's angry. She's pissed off at the disease. She calls me up and says, what are you going to do now? How come I haven't heard about the therapy you're going to start? And what are you going to do to get it approved? A very helpful coping strategy in terms of the emotion-based coping. She's very good at it. Always avoid fear by finding a hopeful alternative. There are hopeful alternatives at every stage of disease progression. You just have to orient yourself towards them. They do make a difference, and they're very likely affecting your immune system. And then lastly, my favorite expression, if you get your head in the right direction, your body will follow you. Now, with that, I'd like to pause here and enter into the discussion part of this, if you will. I'm going to bring online Dova. Are you there? I don't see Dova. Ah, there you are. Hello, Dova.
Hello.
So Dova can help us with the discussion. If you have any comments, questions, I'm happy to discuss. And again, if anybody wants to see any of those papers that I wasn't able to go into further, I'll be happy to send them to you with an email address.
So the first question that we have is, do you see monoclonal antibodies or mRNA as potential future solutions to end MG once and for all?
Well, yes and no. I definitely see a role for monoclonal antibodies. In fact, we have monoclonal antibodies right now. Ravulizumab, or Rituxan, is a monoclonal antibody that affects your immune system in a certain place. Eculizumab, or Soliris, is a different monoclonal antibody that affects your immune system in a different place. And ravulizumab is the one that's in testing right now that perhaps will be more conveniently, it's very similar to eculizumab, Soliris. So, and there are other monoclonal antibodies as well. The crux of the problem is, even though we understand very well what happens in the immune system with this antibody being produced, we don't exactly know why your immune system made a mistake, as it were, a mistake in that it's creating an antibody against something that it's not supposed to create an antibody to. These monoclonal antibodies are very effective at mitigating that mistake, but they're not so effective at figuring out why that mistake was made. So the answer is, I think they're going to be very effective treatments in our repertoire. I don't know if it's going to wipe myasthenia off the map, because there's some endogenous internal process in your immune system. And it's not unique to myasthenia. There are many, many autoimmune diseases where your own immune system is attacking your own body. Myasthenia is just the example that you're most familiar with. But that process of why the immune system makes a mistake is really what we have to understand more to take myasthenia off the map.
Great, thank you. The next question is, how concerned should I be about the destruction of my receptors over time, as I'm only a Mestinon user?
It's a very good question. Not too concerned, because one of the benefits in the peripheral nervous system where myasthenia is affecting is those receptors can be made again. You're recycling and regenerating those receptors. So the reason you're only on Mestinon, I'm assuming, is because Mestinon is working for you and it's sufficient. Oftentimes, when Mestinon is good but not good enough, we will also introduce an immunomodulating drug, something to buffer the effects of that antibody on and lessen the destruction. But if your myasthenia is at the point where Mestinon alone is controlling it, then I wouldn't be worried, because chances are you're recycling those receptors sufficiently or regenerating those receptors sufficiently to keep up. But that is the next step, is to calm down the immune system. I wouldn't be concerned about being only on Mestinon to manage your myasthenia.
So this is more a comment than a question. Fear also impacts caregivers. They become
Absolutely.
apprehensive to the person with MG live. So I don't know if you want to comment on that.
I think you're absolutely right. I think fear affects your loved ones, because they are the ones that are seeing what you're going through, and they also don't know what's coming next. It is an unpredictable condition for them as well. So my comments about being hopeful, being confident, really should transcend to the caregiver as well. And what I do in my practice is I am very encouraging of the caregiver to come to clinic, because if we can give a sense of well-being, a sense of possibility of hopeful alternatives to you as the patient, I want your caregiver to see that at the same time, because it will affect them. But absolutely, this can be very impactful on your caregiver.
Thank you. We do have a lot of requests for the articles, so we will get them from Dr. Rosenfeld, and we will post them later this week on the website. Perfect.
Okay.
The next question is, can you explain the difference between binding, blocking, and modulating antibodies?
Yeah. So this is a discovery that came out of the Van der Lenen's Mayo Clinic laboratory that I'm aware of the first time I learned about it. We understand binding antibody a lot. Binding antibody is the one years ago, before we had these subtypes of antibodies, we would just run an antibody and it's binding antibody. Blocking and modulating antibodies are also affecting the acetylcholine receptor, but not in the same way. So sometimes we see combinations of these. All three are affected, two of them are affected. Sometimes, especially in ocular myasthenia, you may see just one type affected. So they're all of significance, but they're not all of equal significance. It depends upon, in conjunction with what we're seeing clinically in a patient. Along that same line, a related question would be, what is seronegative myasthenia? Well, how can you have myasthenia if you can't find the antibody? It's along the same line, because in my opinion, antibody-negative myasthenia is just myasthenia in a person where we haven't figured out what the antibody is yet. It doesn't mean there isn't an antibody. It means it hasn't been identified yet. And at one point, that was probably the case in patients that had modulating antibody positivity. So now we have additional antibodies in addition to binding, blocking, modulating. And those are not all of the same significance, but we have MuSK antibody, a different presentation of myasthenia. We have LRP4 antibody, a different antibody. In the future, we're going to be adding to the lists of antibodies that can cause this. And there will be fewer, I think, there'll be fewer seronegative patients as a result.
Great. The next question is, my breathing is my biggest barrier to exercise. I would like to be able to exercise. What do you suggest for those of us with neuromuscular breathing weakness?
Yes. So it's a little bit of a complicated question to answer without more details, but it's a common issue. So in my practice, if I had somebody, as you've expressed, that wants to exercise in their breathing, I would do everything I can to tune up that condition so that breathing is not as much of an issue for you. That is, have I optimized the medications? And of course, not knowing at all about your course and your medications, it's a hard thing for me to address. But certainly the first answer would be try to make breathing less of an issue. That said, if that's not possible or that's not readily possible, there are many exercises that can be done and that are not as impactful on breathing. They're less aerobic. Mild exercise, yoga. Yesterday I tuned in a bit, and some of you may have seen that demonstration of yoga there. Very good, low impactful. Even if you're short of breath, I think that you would be able to accomplish some of that. Generally speaking, walking in water, floating, kicking, using a swimming pool. Less, certainly you need to breathe, of course, but you can modify your exercise pattern, range of motion exercises, stretching exercises, some yoga techniques. All of these things can be impactful, as well as trying to better control the breathing so that you can feel have more choices in the type of activity you go through.
Great, thank you. The next question is, I can appreciate the idea of being hopeful and that MG has many treatments. What thoughts can you offer for when you are going through the list and treatments are failing?
Well, I don't have an easy answer to that because it can be challenging, and I find something. I guess I don't have that in my possibility that I'm done. There's always something that can be done. So I don't necessarily think that there's a case of myasthenia that responds to nothing. Sometimes you have to be a little creative and you have to be a little bit more aggressive at what you try, but it should respond, or I start looking for other diagnoses. If you have an antibody, and removing that antibody with plasma exchange, suppressing that antibody with immunomodulating agents, treating the neuromuscular junction with mestinon, if none of those things are working, I have some thoughts about what I would do clinically, but to answer your question is you just keep trying, you just keep going because something should work. Not everything works equally for all patients, but my baseline for all patients, honestly, is normal function. When I meet a myasthenic, even when I meet a myasthenic in crisis, my thought process is, what am I going to do to get them back to normal function? Not better function, normal function, because this is an autoimmune disease in a part of the nervous system that regenerates. And if I can put that autoimmune disease in check, they should experience a very significant benefit. And if I see a person that's sort of happy with what they got, and what they got is a fairly disabled existence, I really challenge them to try to do better and try to let us figure out how to get them to a higher level of function. Raise the bar.
The next question asks, there are so many negative opinions and outlooks on social media. How do we find hope and ability to cope on social media like Facebook and Twitter?
Well, I guess my short answer would be you shouldn't be guiding how you feel about yourself and your condition by what you're reading. You know, I used to tell my children this when they were growing up. You could learn about yourself from the inside out or the outside in. That's what mine. So the inside out means, how do you feel about this? A talk like this, or conversations that you've had with your healthcare provider or with your friends or your support group, and that sense of possibility, why would you let that get taken away from you by someone on the internet who doesn't know who you are, who doesn't know what you're going through, who doesn't probably understand myasthenia? So if you're reading posts from patients that themselves have myasthenia and they're very depressed and depressed and desperate and negative. It's sort of optimistic, but I would say that's an opportunity for you to say, hey, you're on the wrong track, and not take their words and have it affect you, but have your words affect them.
Thank you. It's difficult to cope or have a positive attitude when you have depression. How do we avoid getting stuck in depression when MG robs us of so much?
Yes, that's a great question. And I didn't really get a chance to talk as much about that in some of the papers, but depression was a very common covariate that offsets quality of life, because depression is a real entity. It's another disorder. It's a concurrent disorder. It means it goes along with the myasthenia. And very frequently, when a person is clinically depressed, even if it's a reactive depression, that means as a result of your condition, I will use an antidepressant medication to help with that, as well as strongly encourage some therapeutic interaction, either with our therapist in the program or a therapist local. It doesn't even have to be a therapist, just somebody who can provide a therapeutic interaction. Sometimes it's a clergy person, sometimes a social worker, sometimes a psychologist, but you do have to look at the depression not as a byproduct of the disease, but as a concurrent disorder. In other words, something else that has to be treated separately and at the same time as that. So that's a very good question. And the fact that you would identify yourself as having depression is a wonderful first start. Now the key is to try to aggressively manage that as if it was a completely separate disease that impacts yours. But 100% don't ignore it.
Great, thank you. The next question is, with MG becoming a disease that can be controlled as compared to many decades ago, do you see the disease being referred to as just myasthenia instead of with the gravis suffix?
That's a good question. I think, I suspect it'll always be called what it is, but I say when I refer to it in my notes, my documentation, I'll say myasthenia well controlled, or myasthenia gravis. I suppose I could say MG well controlled. I think I don't think they're going to change the name, because I suspect they're going to need to account for the same entity sometimes not being well controlled up until the time it gets well controlled. But there probably should be a separate term for, in remission or, well-controlled disease. I don't know that they're going to change the semantics of the title of the name of it, because it is unpredictable and you never can let your guard down. I saw somebody last month who had been in remission for 22 years and came to me with what for all the world looked like classic myasthenic resurgence of the disease. And we're treating him, but he didn't really have to worry about this for 22 years.
So we're coming up to the end of the session, but I have one comment to read and then one more question. The comment is, after losing my community-based Tai Chi classes, I started walking daily. The joy of being outside and in nature has a great emotional boost and has helped with strength and breathing. So Excellent. That is the comment. And then the last question that we have is, if a person is diagnosed with thymoma, could they have non-symptomatic MG, and should they be tested for antibodies to AChR at that time?
Yes and yes. So thymoma is a problem for two reasons. Is that if you have MG, it can make the MG worse, and if you don't have MG, the thymoma can then go on to become a more significant problem in and of itself, just by virtue of it being a benign tumor-like growth. So thymoma needs to be taken care of, and you probably should get acetylcholine receptor antibodies drawn for your thymoma. So the answer is yes on both of those.
Thank you, Dr. Rosenfeld. This has been a fantastic talk.
I just have
Sure.
one comment, if I could, before you sign off. As I mentioned at the onset, for me, this is a very unique talk. I'm used to talking about the science and the pharmacology and whatnot. I've enjoyed putting this together, and I wish I could be in the same room with you so I could have had more of a dynamic interaction. But for myself, I'm interested to know if this type of talk really was useful for you. And so any comments you could write back to the organization with regard to this talk that they might be able to forward me, that'll really help me decide whether I should consider giving this type of talk again. This topic was well covered, or was there something that you wished we had covered that I didn't? This is very constructive for me as I go forward to decide about giving this presentation in the future. So I thank you all very much for your attention and your great questions.
We are getting amazing comments in the chat, in the Q&A, of people that are really enjoying the presentation. So we will collect those and forward them to you. So
Sure.
Thank you again very much. We are going to take a short break, a 10-minute break. Everyone can visit the exhibit halls. We will be back at the top of the hour for our patient spotlight session. So thank you, everyone.
Bye-bye. Thank you.